Good evening, it's Dr. Mind. I'd like to discuss SNRIs briefly. It's a dual-acting antidepressants. They're not SSRIs like fluoxetine, sertraline, paroxetine, citalopram, or escitalopram. No, not like those. And they're not like NDRIs like bupropion or NRIs. They're called SNRIs, serotonin norepinephrine reuptake inhibitors, or dual acting. They work in two areas of the brain, not just serotonin, not just norepinephrine, but both. Now you have the first one that went generic recently, venlafaxine. That shit is so strong that if you miss a dose, you can crash into suicidal depression. In the old days when they had just the short-acting house-shaped venlafaxine, TID, man, that was scary. Then they came out with the long-acting capsule, 37.5, 75, 150. Then you can go up to 225, but after that it becomes dangerous. I don't really like side effects or venlafaxine. I make fun of it. It's generally too strong. Like, how in their right mind could it got approved for generalized anxiety? That's always puzzled me. Okay, then you had the second one come out called duloxetine. Now it's made by a big company, it's pretty expensive, and it's an inducer. No. Yeah. Of other medications, they don't tell you that. So as far as drug-drug interactions, there are some that are overlooked. It can affect other drugs. However, it's pretty good, duloxetine. I've had good results, I guess. I go to 30 and then 60. In most cases, it's pretty bad depression. Sometimes I'll use 20, but I titrate it up over about 2-3 weeks from 30 to 60. I don't go above 60 because of the liver issues. Okay, and then you have the new one, venlafaxine. That used to be made by a bad company, I guess, but now it was bought out by a bigger, better company. Venlafaxine. Venlafaxine is venlafaxine is paliperidone is risperidone. So it's an active metabolite that has no drug-drug interactions that are significant at this time. Therefore, it's good if a patient is depressed and on multiple other medications, medical meds, pain meds, antihistamines, statins, antihypertensives, because there's not a lot of drug interactions with venlafaxine and the other medical meds. So these are your SNRIs, and I know it's silly. Okay, this is the biggest scam I think I've ever heard, and it's led to probably a lot of problems. You take the SNRI, and then you try to add stimulant. It's not that simple. You can't I certainly would not take duloxetine and add amphetamine for depression. And then you see the trazodone at night. So there's 3 stimulating medications in that sense. This has not been shown to be proven. I think it's more of a scam, a marketing scam. So I discourage my patients from trying to add, say, methylphenidate to venlafaxine. You're asking for trouble. I'll bet you they had to add some for anxiety or sleep after that, huh? So you need a downer to counteract the 2 uppers. try to discourage this. Anyway, that's my take on the SNRIs. I kind of like them because clearly SSRIs, especially most of them are all generic now, or weak relatively. The NRIs aren't even approved and all over, and there's only been the bupropion in America. And the MAO, now you know what, an MAO, that's what an MAO is, an SNDRI. Now that I'll buy. But I like the low-dose MAO inhibitors that don't have the diet restriction, vis-a-vis selegiline patch transdermal, where the 6 milligram doesn't require a diet restriction, with the 9 and 12 milligram does. So technically you can make that, but it's not as simple as the effects are in methylphenidate. Nice try.